Running an ambulatory practice today isn't simple. Leaders are balancing patient care, staffing pressures, financial performance, and rapidly changing technology all at once.
Welcome to In Practice, a podcast focused on the latest in ambulatory care, what works, and what leaders need to know to help their practices thrive. Hi, I am Dr. Robert Murry, the Chief Medical Officer at NextGen Healthcare and a practicing family medicine doctor. This is In Practice, a podcast where healthcare leaders, clinicians, and practice administrators discuss challenges ambulatory practices face every day with strategies to overcome them. Community health centers have always cared for people with complex medical, behavioral, social, and economic needs. They focus on prevention. They know their communities, and they often keep patients connected to care, even when the system around things seems to be making that harder than it should be. Now, this is why value-based care is such an important conversation for health centers. And in many ways, the model is catching up to what community health centers already have been doing for many years, delivering whole person care, improving access, and helping patients stay healthier over time. But for value-based care to work in the real world, the full complexity of the patient needs to be visible. Documentation needs to support accurate risk capture. Reimbursement needs to reflect the work that's actually being done. And as Medicaid continues to change, health centers need proactive strategies to really help eligible patients maintain their coverage and stay connected to that care. Today, I'm joined by Bob Theis, the Chief Executive Officer at Rodgers Health Center in Kansas City. Bob is passionate about value-based care and often describes it in a simple but powerful way. It's when doing the right thing pays. So, Bob, welcome to the show.
All right. Thank you, Dr. Bob Murry. How are you doing?
I'm good. Thank you again for joining us. It's great. All right. So I said that community health centers have been for a long time delivering whole person care. But for a long time, we've also been talking about value-based care. It's just around the corner. You know, everything's going to move to value-based care. 100% of Medicare patients are going to be on value-based care by blah, blah, blah. Do you think that now is finally the time that value-based care as a concept is going to take off? And are CHCs, community health centers, going to be part of that shift?
We have been, like you said earlier, we have been part of this. And we've been fortunate enough that as fairly qualified health centers, we've had to report our UDS numbers on an annual basis. And that does so many different things. Number one, it has you looking at your quality. Number two, it gives you a story to tell. And we're so fortunate to be a bipartisan supported effort. Both sides of the House support us, Republicans and Democrats, and it's because we can tell our story. And when you can make numbers tell a story, when you can tell any story well, it really helps everyone.
And so then how do CHCs tell the story of value-based care?
We get to look at data on a regular basis, and we can see data's been getting better and better on a regular basis. You know, when everyone went from the paper to the electronic, everyone was moaning. I heard doctors wanting to retire. But right now is the time where data is truly at our fingertips, and we can make data-driven decisions on a regular basis to help our patients get care gaps closed, to help them stay connected to care, to help them with automated outreach messages. Do you know it's flu season? It's time for your flu vaccine. It's time for HPV vaccine. And so the tools at our fingertips right now, today, are finally where they are, where the people who decided to make us all use these EHRs, right, for Medicaid billing, Medicaid, Medicare billing, we're finally seeing them mature. And so right now is the best time ever to get involved in value-based care. And I'm just going to say that value-based care, what you may have said a little bit earlier, if you don't know the risk adjustment factors for your patients, how are you treating your patients? And so what I've seen more now than ever is a concentration on those risk adjustment factors. because those managed Medicare organizations, they want to get paid at the highest risk level for their patients. And I'm not sure, I know you know this, but I'm not sure everyone knows this, that if you have your toes cut off because you're a diabetic patient, you have to code that every single year. And if you do not code that, miraculously, people think that your toes grew back. So risk adjustment factors, being as detailed as you possibly can. We are investing in understanding how IMO can help us get those right at our fingertips so we can put them in every single time. Because to me, I just met with 3 different managed care organizations, and they are all telling me, Bob, we need these risk adjustment factors put in. And that's where the biggest bang for our buck is right now.
Sure.
It was closing the care gaps, but now it's these risk adjustment factors.
Yeah. All right. So there's a lot to unpack there. Just for any folks in the audience that might not be completely familiar with what Bob is talking about here. So for most types of value-based care arrangements, you get extra payments, right, based on supposedly the value of the care that you deliver. But you tend to get more money if the patients are complicated, right? Complicated patients require more care. And so if you're going to get paid based on that rather than based on everything that you do episodically, you need a way to demonstrate or to reflect that complexity, and that's done with these risk adjustment factors, as Bob is saying. And the way that they're calculated both makes sense and is kind of ridiculous with the example that he alluded to, where you have to code these every year. Otherwise, somehow all of the patients' issues that were present last year are magically cured on New Year's Eve until you code them again for the coming year. But backing up a little bit, right? How I think risk adjustment factors are one way, but how else can community health centers show the value of the care that they are delivering? Like you mentioned, using data to help patients at the point of the care and to reach out to them. But how do they tell that story that you alluded to in the beginning about the value that they bring?
Fairly qualified health centers are uniquely positioned to do so many different things well. And one of the things that Sam Rodgers does really well is we wrap our arms around the whole patient. So it's not just their diabetes, but it's making sure that their refrigerators are turned on and they keep their electricity. And so we help with wraparound services. Our community health workers are amazing. They have a whole Rolodex of different resources that they can refer our patients to and make sure that they're in a good place so they can successfully take care of their own health conditions. When you can show that you're making progress in constantly improving patient outcomes and reducing the ER visits, we have something in the state of Missouri called the Patient-Centered Health Home. And what that is, it's a group of patients that are in a cohort that have multiple chronic diseases. And the first year that we put this into operations, that same group of patients, so it was 250 patients, and they had about 1,500 ER visits. In the first year alone, we got those same group of patients that had 1,500 ER visits down to below 400 ER visits.
Wow.
And that clearly demonstrates to funders, to managed care organizations, that we're adding value by keeping people out of the ER. You have to show your community benefit. And so keeping people out of that ER is a huge community benefit.
Absolutely. Yeah. Both resource wise and also leaving the emergency room available for people that have emergencies. Right. So that's amazing. Are there examples that come to mind for how CHCs can show the value of the care that they're delivering, even if it's beyond the risk adjustment?
So beyond the risk adjustment factors, there's not much a community health worker can do with the risk adjustment factors. However, those social determinants of health, I always ask people, why are we asking the question if we can't provide a solution? It's like having a mammography performed and something shows up and you go, okay, good luck if you find anything. And so what I want our staff to focus on is how do we close these social determinants of healthcare gaps, social isolation. Holy cow, that pops up more and more. The older we get, the more socially isolated we are. And so by connecting people to different resources, Meals on Wheels, that's a check on somebody on a regular basis. So when we can connect people to services like Meals on Wheels, that's also not only solving the food insecurity, but also solving some of that social isolation.
Yeah, that's terrific. I agree. What are some other activities maybe that either community health centers or, providers in general do that are just not captured by traditional, what they call fee for service? You get paid for every action that you do, that the CHCs are doing all the time.
We do so many things outside of what we get paid for. Right now, there's not a fee for service for community health workers. We're not getting paid for every person we get signed up for Medicaid, but it helps the whole system. So we want to make sure that in these huge changing times ahead for Medicaid, that, but we help keep Medicaid members covered. So we're making sure that people keep up their address, update their address, that they know their redetermination date, they know where to get help, they know what to do to keep their Medicaid. Because people with multiple chronic conditions are going to find out when they go to the pharmacy to pick up their medications that they're no longer covered.
Yep.
And so that regular communication, that when someone talks to Tammy about keeping their appointment and Tammy reaches out on a regular basis, they're going to keep their appointment because they have that relationship with Tammy, who's a community health worker.
Yep. And unfortunately, the fastest way for a lot of those folks to end up back in the ER as often as they did before you, started caring for them in that cohort, for instance, was to lose their coverage or to lose contact with, their care team. I mean, just as a philosophical question, do you think that community health centers might be better at delivering value-based care than, relatively large private practices or, big health centers?
I went to a Medical Group Management Association leadership meeting, and there were very few nonprofits at those meetings. And there were a lot of for-profit. That's when we bought into AI tools. That's when I bought into AI tools. And then I went to a NextGen conference right after that. And AI was making so much, NextGen was making so much progress with their AI tools. And so what I'm saying is when I first went to that Medical Group Management Association, all the for-profits viewed all these social determinants of health questions as an unfunded mandate by the federal government. And federally qualified health centers just think that's just the way we're supposed to care for people, by wrapping our arms around making sure they have everything they need and providing them the resources that they don't even know exist. And sometimes I use this analogy, and if you ever heard me talk, if you don't know what's on the menu, you can't order it. And so many patients don't know what's on the menu.
Yeah.
And so there are things that aren't on the menu that you can special order too. So that's what fairly qualified health centers do. They help people find those resources that they need, and some that they don't even know exist that they need.
Yeah, it's an interesting way to frame some of the mission of CHCs for sure. So you alluded to a couple of examples of technology in our conversation so far. You alluded to IMO, which I think is Intelligent Medical Objects. It's a company that might help you with the RAF scoring, you said. You alluded to some AI. So talk to me a little bit about how these tools help document better, help show the value of the care that you deliver, help you with the value-based contracts or arrangements, or otherwise help you with your mission.
So I look at these tools as a way to reduce administrative burden. 60% of our providers' time was spent in the electronic health record. With tools like AI, ambient listening, we have providers who used to spend their day off getting caught up with coding and charting. And now they can walk out of the exam room, review the notes, realize that, oh my God, this technology picked up things that they forgot they spoke about, but they make sure that the note is appropriate, has everything it needs, sign off, and then they're done. They don't have to go home and remember what they did that day or 2 days later. It's all documented right there. And the IMO, it suggests the appropriate coding. So instead of, now, I'm not a doctor, so I don't know what this is. Instead of just a general diabetes diagnosis, they can get more specific, kidney-related failure diabetes diagnosis. So you can probably explain that a little bit better than me, but these tools make it easier for our providers and reduce that administrative burden. And while reducing that administrative burden, it's also a recruiting tool because people can get home and work their regular hours and not have to worry about things after hours.
Yeah, for sure. I mean, I think when ambient and AI scribes are working well, the effect that it can have on providers' well-being and their ability to get home on time and be with their families and stop doing work outside of work, all that can be pretty profound. So, any other technologies that are coming to mind as you think about CHCs and value-based care? And
we're so excited with what we can do with automated outreach, welcome calls, appointment scheduling reminders, text reminders. We can do flu campaigns and just remind people that of all the things that they need to be reminded of.
You said that you were talking with several managed Medicaid organizations, and that those conversations were kind of promising. So, like, what did you guys talk about? And what should other maybe CHCs know about those conversations?
So managed care Medicaid organizations are very vested in keeping people on Medicaid, the same people that we care for every single day. So they are researching what they did during COVID to keep people on Medicaid. They're learning the lessons, evaluating, finding out what the requirements are going to be for adult Medicaid expansion, the adult Medicaid expansion population, and finding the best ways to do it as efficiently as possible. So why not team up with someone who is financially invested in the same thing you are?
Yeah.
We Medicaid is our best payer. And so at Sam Rodgers, Medicaid accounts for 80% of our patient revenue.
Wow.
We really can't afford to have people fall off of Medicaid. So we're trying to do everything we can to inform the patients and our community partners, churches, other healthcare organizations, other safety nets that aren't in the healthcare field, most of which who don't realize all the changes that are coming. Yeah. It's very scary when I'm in a room talking about the changes coming to Medicaid and people will raise their hand and say, I've never heard of that. But we all need to get that message out. I think that's a perfect opportunity for National Health Center Week. You know what? Invest in how you're going to keep people on Medicaid.
Yeah.
We'll help keep your Medicaid members covered. That's our message to managed care organizations.
Yeah, I mean, you and those organizations may not always see eye to eye, but you are certainly aligned in trying to make sure that people have coverage, and able to get the care that they need, from you or from whoever. So, all right. Well, I mean, we are nearing the end of our time here, Bob. Let's back up a step, and 3 years from now, what do you think is going to be in store for community health centers?
3 years from now, the AI technology is going to evolve so far. I really think that at Sam Rodgers, 63% of our patients are best served in another language. I really think that AI is going to help out with that. I think it's going to help the whole care team. I think that it's going to help MAs, LPNs, all the way to community health workers. And I don't want a front desk anymore. I want community health workers to be at that front desk. So when they get the feedback from the questionnaires for social determinants of health, they can immediately start connecting patients to resources. So I think the administrative burden will be heavily reduced, and we'll be able to do more and more for our patients, and with less administrative burden. That's what I think the future holds for federally qualified health centers. And the more we can go to direct patient care, to direct connecting to other benefits, the better value we are to our patients, who are the most vulnerable in the United States. The federally qualified health centers help 10% of the most vulnerable people in the United States, 30 million people. We're there to make America healthier.
Yeah, terrific. All right. Thank you so much, Bob, for joining the show. Interesting conversation, lots of different topics. So listeners, thanks for making time to join us for today's episode of In Practice. Be sure to subscribe on Apple Podcasts or on Spotify so that you never miss an episode. Until next time, thank you.